Good afternoon. Let me welcome again our stroke expert, the medical director of the stroke program and the chair in stroke prevention at McMaster University, Professor Michael Sharma. We had recently an interview about stroke management, and we got some follow-up questions. I hope to answer them today. Professor Sharma, the first thing is, how do you deal with a person who has atrial fibrillation who shows up with a stroke?
That is a very good question. So, that the probability of that happening, depending on the age of the patient, but if you look at stroke patients overall, is something like 6% at the time of their presentation. If you follow them closely, maybe in the next year, up to 10% will have it, again, depending on age. When you get past the age of 80, it's almost a third of patients who have atrial fibrillation underlying their stroke. Now, the key differentiator between ischemic stroke associated with atrial fibrillation and that which doesn't have atrial fibrillation is the use of anticoagulation. So the two areas in stroke prevention where we'll anticoagulate are mechanical valves and atrial fibrillation. In atrial fibrillation, a few points to consider. The first is when to start it and in whom to start it. Generally speaking, it's easy for stroke neurologists. Anybody who's had a stroke or TIA really meets CHAD's VASC criteria to anticoagulate. I think in primary prevention, you want to look at the CHAD's VASC criteria to help you make that decision. So for us, once you've had a stroke, and let's deal with stroke, the decision is to anticoagulate. And the second point is when to start the anticoagulant. This is a decision that's based really on the size of the infarct. Small infarcts, you can start within 48 hours, so within 2 days. TIAs, you can start them right away. And by TIA, what we mean are symptoms generally that have lasted less than 10 minutes, which are completely resolved. The exam is normal and the CT looks normal. In those patients, you can start it right away. Thing to remember with direct oral anticoagulants, factor 10 inhibitors or direct thrombin inhibitors, is that their action is within 2 hours of ingesting the drug. So you'll be anticoagulated immediately. For people like myself, and I think like yourself, Roman, who trained with warfarin, where there was a delay between starting it and the anticoagulant effect. So minor strokes within 48 hours, major or moderate strokes, and these are judged by the imaging. So you'll need your radiologist usually to help you with that in about a week. So we have that current dichotomy. Anytime you start it after a passage of time, it is recommended that you repeat a CT scan within 24 hours of starting, and that is to see if there's been spontaneous hemorrhage in the area of infarct. Now, the probability of that is about 10% overall, depending on the type of treatment patients received, and sometimes it can be delayed. So we usually do it the day we're starting, ensure there isn't any hemorrhage, and then we start the oral anticoagulant. Now, those timelines are similar to interruptions of anticoagulants. Say you have somebody with atrial fibrillation already anticoagulated, and they present with an ischemic stroke. We will interrupt the oral anticoagulant for about the same time, about 7 days if it is a medium-sized or large-sized stroke. Check again for hemorrhagic transformation, and then restart it. One thing to remember is strokes related to atrial fibrillation are much more likely to undergo hemorrhagic transformation than strokes due to other causes. And it is because the vessel spontaneously recanalizes, so blood flows back to the damaged tissue and hemorrhages.
Just to follow for my understanding, you obviously did a CT before, then you start anticoagulation depending on the size. And when do you repeat the CT with a day later?
Okay, so that's a great question. Generally, we do not repeat the CT after starting the anticoagulant. And the reason for that is that two things to know. One is petechial hemorrhage, little bruising, and you'll see these in CT reports is very common, is not a contraindication to anticoagulation. And if you look at the evidence we have, nobody has suggested it's safer to repeat the CT afterwards.
So you repeat it before starting anticoagulation, not after. Okay.
Not
now,
after.
now I understand. Okay. Now, we were mentioning before that the patient who is already anticoagulated and has an atrial fibrillation is not an immediate candidate for thrombolysis. How about clot retrieval?
So that is one of the situations where we will use clot retrieval without thrombolysis, no matter what the timeline is. So if you can find an occlusion, which is in a proximal vessel, one that you can reach, we will absolutely do clot retrieval there. Now, one thing to know in that setting is the thrombi, the emboli that occur are relatively large. So in that setting, very often we find it proximally. If I can say one thing about anticoagulation, which I think will be useful to this audience, is be very careful about underdosing the anticoagulant. Please follow the label. One of the things we've seen in the data are people that are most likely to be underdosed are older women. And what happens to them is they do not have a lower risk of hemorrhage than people on the correct dose, but they do have a higher risk of stroke. So very carefully follow the label guidelines and use the correct dose for that patient.
All right, well, that is all very helpful. I thank you very much for both healthcare practitioners and for the patients with atrial fibrillation. I hope this knowledge will help us to make decisions and will help patients a bit. Thank you very much, Professor Sharma.
My distinct pleasure.